Hi, I'm Jennifer Salopek. I'm the founding editor of Wing of Zock. I'm here with the team that won the Clinical Care Innovation Challenge from Vanderbilt University. Would each of you introduce yourselves, please?
Sure, I'm Heather Reidinger.
I'm Jennifer Green.
I'm Dr. Jesse Ehrenfeld.
I'm Morgan McDonald.
So you guys won the Innovation Challenge this year with your continuity clinical experience. So Jesse, tell me about CCX.
Sure, the continuity clinical experience is a new part of a required longitudinal component of our curriculum at Vanderbilt, and the goals of the course are really to embed students in the clinical care team so they can really start to not just learn how to be an internist or a specialist, but learn how do you work within a system, identify problems that might come up in that system, and then develop approaches to solving those problems.
You say it's required, so every entering student participates in this?
All students have started this. We're now about to launch our third year of the program. It actually goes back almost 5 years now. We started with a small pilot supported by the Josiah Macy Foundation called the Vanderbilt Program Interprofessional Learning. And we've now scaled that to every student in the entering class.
So Jennifer, what are the main components of CCX?
The main components of CCX are that it is a longitudinal program, so students return over and over to the same preceptor in the same clinical site and the same clinical team. The students can then be involved in the day-to-day activities of that clinical team and caring for patients in that situation. Students also are asked to participate in small group sessions. They have very consistent small group facilitators who lead these sessions and are able to debrief in those sessions from their previous clinical experiences and then learn about the new topic that is at hand, such as medication reconciliation, health coaching, or thinking about the various team roles and responsibilities that occur within their clinical teams.
Heather, how are the students matched with the preceptors? Is it based on the specialty that they think they might want to pursue?
Well, one of the unique things about CCX is that we actually have a variety of clinical specialties. So we're not confined to a particular clinical environment such as primary care. And students enter, we have about 103 different clinical sites, including primary care, subspecialty care, surgical care. And students are matched according to their college and availability of preceptors.
Okay. Heather, tell me a little bit about the gaps or the needs that the program was designed to address.
Sure, a lot of the changes in the curriculum at Vanderbilt have to do with trying to meet the needs of a changing healthcare system and healthcare environment. And so a lot of the needs that we determined was that the students that we were graduating were not graduating with any sort of quality improvement, training, knowledge, no knowledge of the systems at hand. And so our course is really designed to meet those sorts of needs, where we teach students about the systems of care. We put them in a clinical team immediately so that they are part of a team. They can recognize almost as a fresh pair of eyes about what's going on. Initially, they are still very new at the system and new at the whole environment. They're trying to learn about the clinical care, but eventually they start to recognize patterns in the system, problems in the system, and as they grow in their experience and skill set, they eventually are enabled to change that system.
Great.
And I think one of the most exciting parts of this whole process is the fact that the hospital and the healthcare system has operational needs.
Mm-hmm.
There are certain quality improvement initiatives that are going on. We recognize that there are problems. It's a way that we can actually plug students through their care teams into helping the hospital solve some of those problems. And that's one of the really innovative parts of what we've been able to scale across every now entering medical student.
One of the other fairly innovative curricular design elements that we instituted was a seminar session so that each of the students comes back to a consistent group or a team of students to discuss their individual clinics. So it allows really a breaking down of silos of sorts between these specialty clinics, between the surgical clinics and primary care clinics, so that they can come back and talk about these skills that they've learned, how they are implementing medication reconciliation, for example, or health coaching, or quality improvement skills, and compare and contrast those clinical environments.
Jennifer, were there any big challenges you had to overcome in designing and implementing CCX?
I think the biggest challenge was finding preceptors who understood what the goals of the course were. I think certainly our preceptors are very used to precepting students who are third and fourth years in a clinical environment and knowing what that looks like. They had a model for how to approach teaching in that environment. So I think finding preceptors and coaching them through that this is not an early clerkship, that this really is a systems-focused and healthcare delivery-focused course, and that the goals and objectives are very different than the students that they had interacted with before. I think the other challenge is finding preceptors who are able to volunteer their time, we had some logistical considerations in terms of what days the students needed to be in clinical settings. And then I think just having the physical space for preceptors to have students within their clinical setting was also a challenge.
So Jesse, how are you measuring your success?
Well, we've gotten some wonderful feedback from both our students and our preceptors, as well as some of the work that's actually gone on. And we know that in some of the quantitative data we've gotten back in terms of surveys, that the course has been highly rated by both students and faculty. I think one of the best measures of success is that our preceptors in the program overwhelmingly tell us that they would recommend participation in the program to a faculty colleague. We think that that's a really nice marker of how well this has gone. Finally, I would say that in the first 18 months of the program, the students identified over 200 potential problems that were amenable to systems-based solutions that we now have pushed on into moving things forward from a quality improvement standpoint.
That's great. So what advice do you all have for viewers in other institutions who might want to implement a similar program?
So I think having institutional buy-in within the clinical departments is very important. I think that as with all teaching efforts, it is very important that the preceptors, the boots on the ground people feel that their role is important and that their role is valued. And so having clinical leads, clinical department chairs who are willing and able to help facilitate these preceptors taking students into their clinical environment is very important.
I would also say having a team to pull this kind of a project together was really, really important. We started small with just 8 students in the initial pilot, and that went on for several years before we scaled to the entire class. But sitting in front of you, you've got physicians from a variety of different specialties. I'm an anesthesiologist, and these guys are all either pediatricians or internists. And I think one of the wonderful things is that we bring a variety of perspectives, we work well together, and the program is something that none of us could have ever done alone.